Okay, so you'll also notice that the closed captioning is up there. That's for you to be able to read what I'm saying to you in real time. In case English is not your native language, that should make life easier. Also, in case you can't hear me, it's up there on the board. Now, what we're going to do is we're going to start with this whole foundations of fluid and electrolyte and acid-base balance and how the body maintains homeostasis. We're going to get into the basic chemistry. We'll talk about some immunity, how it develops, and we're also going to talk about acid-base balance. The reason we do that is those are the foundational elements of pathophysiology and how the body tries to die and how you're going to notice it so that you can do something on its way to death. So we're going to talk about Starling forces. That's how fluid moves in and out of the vessels, in and out of the cells. We're going to talk about renal and hormonal regulation because that's the thing that actually controls the flow of water, essentially. We'll talk about basic acid-base disturbance and how the body compensates and how you can identify it. And then we'll talk about innate versus passive immunity. So let's warm up your brain a little bit. And let's start with this question here. A 50-year-old male with a history of lithium use presents with excessive urination and thirst. The labs show the serum sodium of 150 milliequivalents per liter, very dilute urine. After administration of desmopressin, there is no significant change in the urine osmolality. What is the most likely diagnosis? Is it A, diabetes insipidus, B, nephrogenic diabetes insipidus, C, SIADH, or D, primary polydipsia? What do you think, guys? Why do you think that, guys? What's the problem here? What's going on? Is this person retaining or putting out a lot? Putting out a lot. So it's not going to be C, is it? No, it's not. The answer here is B, nephrogenic diabetes insipidus. So nephrogenic DI, the kidneys do not respond to the antidiuretic hormone. So giving desmopressin, which is synthetic antidiuretic hormone, has little to no effect on the urine concentration. So this is the classic nephrogenic diabetes insipidus associated with lithium. This is a very common occurrence that can happen. If you're talking about central diabetes insipidus, that's typically something that happens due to a head injury or trauma to the brain. Surgery is just trauma that you pay for. Central diabetes insipidus would improve with the desmopressin because the kidneys are not insensate. It's not producing it. That's the distinction there. So that's why it's not central diabetes insipidus. SIADH causes hyponatremia. What's normal sodium? 135 to 145. What's this sodium here? 150. Okay, so this here is too much sodium. So in SIADH, you'd expect too little sodium due to the inappropriate water retention. So no, you would not see hypernatremia and dilute urine. And then, of course, D is incorrect, primary polydipsia. This might cause the dilute urine, but typically the sodium would be lower because why? They're diluting the sodium. Got it? Okay. We're going to do a couple more of these to cause a little stress and to wake up the brain. A trauma patient with poor tissue perfusion is found to have deep, rapid breathing. The blood tests show low bicarbonate and low CO2. Which acid-base disturbance is most likely? Respiratory alkalosis, metabolic acidosis with respiratory compensation, respiratory acidosis, or D, metabolic alkalosis. Show of hands, please, for those that think A. Those that think B, C, D, we need to talk. So the problem here is what? What does a trauma patient do? They hyperventilate. Why do they hyperventilate? To blow off the excess CO2. Why might they have excess CO2? Or why would they want to blow off the excess CO2? What is CO2? An acid, right? What happens when there's poor perfusion in the body? Lactic acid builds up. So if you have lactic acid building up, we want to help you compensate. So we're going to do the best thing we can and get you to breathe faster to blow off the CO2 in order to bring that down so that hopefully your pH will be balanced, right? So the primary issue we have here is this lactic acid building up, lowering the bicarbonate, so the body responds by hyperventilating to blow off the CO2 in an effort to compensate. While CO2 is low in both conditions, for example, C, respiratory acidosis, Alkalosis would not happen. Bicarb takes a long time in order to compensate for that situation. And then, of course, in the metabolic alkalosis state, that is not what's being described here. Metabolic alkalosis would show elevated bicarbonate, and that typically leads to slower breathing. Why might an elevated bicarb make you breathe slower? What happens if you breathe slower? You retain CO2, which is an acid which helps you compensate. Okay, good. Let's do another one. Which cytokine is primarily responsible for recruiting neutrophils to the site of an acute bacterial infection? IL-6, IL-1, IL-8, TNF-alpha. What are we talking about here? We're talking about cytokines and the inflammatory cascade. When's the last time you've heard of this? Don't worry, it'll all come back to you, I promise. Okay, so your answer here is IL-8. And IL-8 is a chemokine and it acts like a homing signal. This is what directs the neutrophils to come to the site to fight off the infection. You should know that IL-6 stimulates the acute phase protein production in the liver. It doesn't do cell recruitment. IL-1, that's responsible for fever and inflammation, but it does not recruit neutrophils. And tumor necrosing factor alpha is increases vascular permeability and upregulates adhesions, but it doesn't cause chemotaxis. Now, what should you do? How should you use this question to study? Well, it's probably in your notes that I gave you, these lovely notes here. There is a grid. You make a list of the cytokines and what they're responsible for. This way you can quickly refer to them. But these are 4 of the ones you may likely see again. Let's do another one. A patient with nephrotic syndrome presents with severe pitting edema. What is the most likely underlying mechanism? Increased capillary hydrostatic pressure, decreased plasma oncotic pressure, lymphatic obstruction, or increased interstitial oncotic pressure? Hands for A. Hands for B. Hands for C. Hands for D. We need to talk. Okay, so decreased plasma oncotic pressure. In nephrotic syndrome, the primary issue here is the protein is leaking out of the body, okay? That's what's causing the pitting edema because the protein is not able to keep the fluid in the vessel. So they have a hypoalbuminemic state. So glomerular damage leads to the increased permeability of the proteins. Massive proteinuria, and when we say massive, we mean about 3.5 grams per day, occurs with albumin being the predominant protein that's lost. That leads to that hypoalbuminemia state, and that develops a protein loss that exceeds the ability of the body, the liver specifically, to produce it. That's where albumin's produced, right? Notice it's on the LFTs. Good. Decreased plasma oncotic pressure results in the low albumin level. The fluid then shifts from intravascular to interstitial space due to these altered Starling forces. And on the next slide, we'll talk about what are all these Starling forces. Severe pitting edema then develops, and that manifests typically in the dependent areas. So what you might notice in someone, say, with nephrotic syndrome is when they wake up in the morning, you'll notice this periorbital edema, sacral swelling, all of the dependent regions, they tend to puff up. Albumin maintains about 70 to 80% of the plasma oncotic pressure. When the albumin goes below about 2.5, that's when the pressure starts to be insufficient to counterbalance the other pressures to keep the fluid in the vessel. So let's talk about option A, increased capillary hydrostatic pressure. That is what you get. That's the type of swelling you get when you have things like congestive heart failure, venous obstruction, fluid volume overload. That's not the problem with nephrotic syndrome. Capillary hydrostatic pressure is typically normal or even decreased due to the intravascular depletion. Option C, lymphatic obstruction, that's a different kind of edema. So these are all different mechanisms by which you can have edema. The reason it matters for you to pick it out is they're all kind of treated a little differently. We don't just give Lasix to everybody. So lymphatic obstruction, this is non-pitting edema. That's usually unilateral. That's when the lymph node gets obstructed. This is the person that may have had surgery with a lymph node dissection of some kind. Maybe a tumor is obstructing the outflow. Maybe they've got a parasitic infection of the lymph nodes. This is basically very localized to a specific area. And then interstitial oncotic pressure, option D, This is not how nephrotic syndrome works. This requires significant protein accumulation in the interstitial space. So while some protein may leak into the interstitium, this is not the driving force. The primary issue is loss of the intravascular oncotic pressure, not gain of oncotic pressure. The albumin is out of the vessel, causing leaking, leading to the swelling that you are seeing. Okay, this can look so bad that you may notice periorbital edema. If it's so bad, you can notice anasarca. So why this matters? If you're dealing with nephrotic syndrome, then the treatment really matters because this is where you're going to give things to reduce the protein excretion in the urine. Maybe ACE inhibitors, immunosuppression. Diuretics are used just for symptomatic relief, and then you're going to manage the protein as well in the diet. If you don't want to overload them, but at the same time you want to get it in them, you want to deal with that damaged membrane that's causing the leaky kidney. All right, we're going to do one more question, and then we'll get into this question. Yes, ma'am.
So hospital.
Steak sandwich? No. You could do plasma. Well, plasma's not protein though. You could give blood, whole blood, and it's expensive, yes, but don't worry, no one's paying for healthcare. It's all free. It's all free. Yeah, because they want you to play that game. But don't get me wrong. The right doctor walks in the door and says, "We're going to give albumin." Okay, we're going to do it. That's a political game. It goes in and out of style. The other thing they do is they'll do like Hespan or Hetastarch. It's transient also, but go ahead. Right. It makes you feel better in the process. The albumin's going to, as soon as you put it in, it's going to wash right out. So if you're actively trying to resuscitate the person and their blood pressure, say 70, suddenly albumin's available because that's called the kitchen sink approach. You know what the kitchen sink approach is, right? Just throw everything at it. We don't know what we're doing. Just throw everything at it. That's when they give them steroids and DDAVP and transfuse and crank up the pressors and turn down the PEEP and right. They do all that stuff. Yeah, they get desperate. They just called Hail Mary. I mean, after that, you do ECMO. What's left? But you need enough blood pressure to run the ECMO, right? So. C'est la vie. Okay, here we go. Which of the following best explains why patients with severe vomiting can develop metabolic alkalosis? They're losing large amounts of sodium. They're retaining too much water. They're losing hydrogen ions from the stomach. They are retaining potassium in the kidney. Show me hands for A. Show me hands for B. A. Show me B hands. Show me C hands. Yay, we don't need to talk anymore. D, they're retaining potassium in the kidneys, wrong also. So here's the deal. These people, when they're vomiting or having diarrhea, they're losing hydrogen ions. What's happening to them? Well, that acid is leaving. They're going to become metabolically alkalotic. So as a result, they may breathe less in order to contain that CO2, just to raise that, to lower that pH, essentially. So sodium loss can result in volume depletion, but it's not directly the cause of alkalosis. And water retention alone would dilute electrolytes, but doesn't explain this. And if they're vomiting and diarrhea, they're not retaining water. And potassium is also typically lost. So you may notice these people that are putting it out are also losing potassium in the process, right? Okay, so let's talk about this here now. Okay, enough questions. I've stressed you out all. Then you're going to start filling the empty bucket. Let's go. All right. So before we think about edema, let's ask this question. Why doesn't fluid just keep leaking out of our capillaries all day long? And what forces counteract this pressure? Why aren't we leaking fluid all day long? What is it that keeps the fluid in the vessel? Wait, didn't we not just go through 5 questions? What? Protein. Thank you. Am I talking to myself here? Okay, listen. The protein keeps the fluid in the vasculature. Okay, this is what's maintaining that fluid volume balance. Other things like oncotic pressures, plasma protein, albumin. That's what keeps your insides in. So the capillary hydrostatic pressure, this pushes fluid out. Capillary hydrostatic pressure pushes fluid out. of the capillaries into the interstitial space. Think of blood pressure at the level of the microvasculature. That's what we're talking about here. The increase in this pressure, for example, in CHF or renal failure, promotes the edema. Okay? Increased pressure pushes the fluid out. Now, interstitial hydrostatic pressure, this pushes fluid back into the capillaries, usually low or slightly negative, but this can rise with compression. So how might this be affected? Tight bandages or compartment syndrome. So that's why if someone is swollen, we may add a little pressure dressing to keep the swelling down after surgery. We want to keep it down. But if we keep it too tight, then we cause a compartment syndrome, which is really bad. But there can be a therapeutic use, but it can also turn pathological. So this interstitial hydrostatic pressure pushes fluid back into the capillaries. Capillary oncotic pressure pulls water into the capillary. So we're talking about pushing and pulling forces. The capillary oncotic pressure pulls water into the capillary due to plasma proteins, especially albumin. In general, when I say plasma protein, you should think albumin. This is why albumin infusions can shift fluid back into the vasculature, but it is obviously short-lived and temporary. Interstitial oncotic pressure pulls water out of the capillaries into the interstitial space. Normally, it's low. This increases can happen in the inflammation process. When you're inflamed, this can increase that interstitial oncotic pressure. So if I give a patient IV albumin, which of these forces am I manipulating? If I give you albumin, which of these pressures am I messing with? I'm increasing which? The capillary oncotic pressure. Exactly. This is drawing water back into the circulation. So sometimes what they'll do is they'll give you that infusion of albumin and chase it with 20 to 40 of Lasix or one of Bumex, right? Why? Because your pressure is high. I want the fluid in, and then I want you to pee it out. I'm trying to get it out of this third space, pull it into the vessel, and have you pee it out. Why might I do that? Well, maybe the third space fluid is keeping you from fully expanding your lungs. Maybe it's causing you pain. Okay, if someone has a leaky capillary, say from a burn, how does this affect the system? Which one is affected? You have inflammation from a burn. Right, increased interstitial oncotic pressure and permeability, and that promotes the edema. Exactly right. So what you should do is go through these and think about patients you have encountered with the different pathologies that you have seen. And now you can think to yourself, oh, what have I seen and why have I seen it? And that will help you do that. So now let's talk about the mechanisms of edema formation. So a couple of things here. Now that we've covered the Starling forces and talking about how we control fluid movement, what happens when this balance goes wrong and we get the edema? So these are the 5 mechanisms of edema. Normally, fluid moves out of capillaries at the arteriolar end, that's filtration, and back in at the venular end, that's what we call reabsorption, with lymphatic clearing any excess. Now, the balance depends on the hydrostatic pressure, which is pushing fluid out, oncotic pressure, which is pulling fluid in, mainly due to albumin, and capillary permeability. Now, when these forces are disrupted or the lymphatics are blocked, fluid builds up in the tissue, and that leads to edema. So in practice, you'll see edema in many forms: swollen legs, pulmonary edema, anasarca. So understanding why this happens will help you manage it. So here we go. Number 1, the increased capillary hydrostatic pressure. When blood pressure in the capillaries rises, it pushes more fluid out into the tissues. So think of this in terms of heart failure. When the heart can't pump effectively, causing blood to back up, this increases the venous pressure. This leads to peripheral edema, swollen legs, or even pulmonary edema or fluid in the lungs. This can happen in people with a DVT, where the clot blocks the vein, causing the downstream swelling effect. The second one I want you to notice here is the decreased plasma oncotic pressure. Albumin in the blood pulls fluid back into the capillaries. If albumin levels drop, like in nephrotic syndrome, where the kidneys leak protein, or say in liver failure where not enough is being produced, or say in malnourished states, like when your elderly person, the one I just saw 2 weeks ago, she had end-stage dementia, and I'm seeing her for the first time. And so I do my $1,000,000 workup just to make sure I'm not missing something, like she's acutely delirious, but I had a hunch. So we do a chest x-ray, we did an echo, we did an EKG, we did basic labs, and I find like a pleural effusion and a pericardial effusion, and she's listless and lethargic. And I say to the daughter, it's time to call hospice sometime in the next 3 to 6 months. She goes, how do you know that? You just met her. Well, she's not eating very much. Well, how bad is it really? Well, it's so bad that she's leaking fluid around her lungs and around her heart, right? She is so end stage, she's so malnourished at that point as a normal decline of dementia. But you can then realize how advanced this disease really is. So this generalized edema happens when there is not enough protein in the blood for a variety of reasons. Either it's leaking out for some reason, or it's not being produced, or you're not taking in enough. The third one I want you to notice here is this increased capillary permeability, as in what happens in cases of inflammation. So think any inflammation, anything that ends in an itis. The most serious one would be pancreatitis. The more common one would be cellulitis. You'd see localized swelling. Or injuries like burns or damage to the capillary walls. This is what makes them leaky. Now, proteins escape into the tissue, they pull the fluid out, causes the swelling, and the edema is often localized and protein rich. In fact, if you tap it and draw it, you can actually send it to the lab and you can find protein in the serum. And sometimes it comes down to just what kind of edema is this, and sometimes you'll just send a sample to see what's in the fluid. It's not unreasonable. Keep in mind that needle poke is also causing damage, so we don't want to make things worse. But just so you know, there are ways to tell more definitively. The fourth method of edema is lymphatic obstruction. Lymphatics normally drain excess fluid, so if they're blocked, like say after breast cancer surgery, removing a lymph node in filariasis is a parasitic infection of the lymph. It's very rare, but something to be aware of, especially if you do wilderness medicine, tropical medicine, decide to go to the developing world, if you want to do medical missions and the like, you will then be alerted to the zebras that may occur in your path. Fluid and proteins build up. This causes the lymphedema, and this is typically non-pitting and also protein-rich. Now, the fifth mechanism of edema is sodium water retention. Conditions like heart failure or cirrhosis reduce blood flow to the kidneys, which activates hormones like aldosterone and ADH. And then these cause the body to hold on to sodium and water, increasing blood volume and capillary pressure. So why does this matter for you? Well, you've been through it all. You can relate this to your daily practice, but each mechanism points to a different cause, and your assessment helps pinpoint, for example, pitting edema, where your finger leaves the indentation, suggests maybe heart failure or nephrotic syndrome. Non-pitting edema, that might point you to a lymph node issue or post-surgery. Or pulmonary edema, you'll hear crackles and you'll see symptoms like shortness of breath, pink frothy sputum. That's important to know. In heart failure, you might be checking the weight daily and you notice the circumference of the waist or the leg is growing. And then you'll know to assess lung sound. So you're always looking for the underlying cause, depending on how you assess that edema to be. That will give you a clue as to what we're aiming for. Okay. Now, I am not turning you all into critical care experts and fellows here. That's not the point of this lecture. The point of this lecture is to give you a sufficient foundational understanding and the vocabulary so that you at least know how to begin the workup, manage, and speak to the consults as needed. In medicine, it's all a team sport. There's no one person hanging on to all the knowledge in their brain. Everyone's constantly looking stuff up. So when I present you this information, it's so that you at least know what to look up. It gives you the language to help articulate what you're seeing, whether you're communicating with another professional or explaining to a patient or deciding how to treat. You at least have the foundational knowledge of how to proceed. All right, let's talk about clinical examples of edema. So pitting edema and non-pitting edema, and non-pitting lymphedema rather, pulmonary edema, anasarca. Edema happens when fluid builds up in the tissue due to imbalances in the Starling forces like high capillary pressure, low albumin, reducing oncotic pressure, leaky capillaries, blocked lymphatics. Those are the mechanisms that tell you the clinical signs to observe. So pitting edema is when you press it and the finger stays. Non-pitting, it doesn't stay. Pulmonary, you can hear it. Anasarca, that's the whole body, usually due to severe hypoalbuminemia. So Let's talk about now regulating osmolality and volume. After seeing how edema forms when fluid balance goes wrong, I'm going to talk now about osmolality, which is about the concentration of particles in body fluids, and volume, the amount of fluid in the body. These are the keys to understanding this condition, like, say, dehydration or fluid volume overload. So if we look at the whole body, kidneys, brain, hormones, they all work together to keep fluid and sodium balanced. So you'll hear about osmolality and osmolarity. So here, let me tell you what the difference is, because every time people always ask this question. What's the difference between osmolality and osmolarity? Don't just say the spelling. Osmolality, this measures the number of solute particles per kilogram of solvent. So think water in body fluids. And it's reported as milliosms per kilogram. It's the standard in medicine because this is the precise body fluid, like plasma, normal range 285 to 295. Osmolarity is similar, but this measures particles per liter of solution, and that's reported milliosms per liter. So osmolarity would refer to IV fluids in calculations. Osmolality refers to the body itself. Okay. So we focus on osmolality. That's what the lab reports to you. So that's what you're going to see on your urine osmolality and your serum osmolality when you're comparing the two. Another concept I want to talk about is this thing called tonicity. Now, tonicity is about the effective particles like sodium or glucose. And this is what drives water movement across the membranes. High tonicity in the body pulls water out of the cells. Low tonicity causes water to enter the cells. So this is why sodium levels matter so much in conditions like hyponatremia. The thirst center in the hypothalamus is what controls osmolality. The brain senses high osmolality, concentrated blood, say dehydration, or low blood volume, like in bleeding. And this triggers the thirst mechanism, prompting patients to either drink when that puts the water into the system. Antidiuretic hormone, also known as vasopressin, that's released from the posterior pituitary when osmolality is high or volume is low. Antidiuretic. It wants you to hold fluid. It prevents diuresis. ADH acts on the kidneys and the collecting ducts to resorb the water, assuming they're sensitive to it, but they're not, like in something that we just mentioned, the nephrogenic diabetes insipidus. That's how you can tell the difference. That's how you can distinguish it. You give them a vasopressin test and it doesn't respond, and you say, oh, it's nephrogenic. If it does respond, it's central. Think of a patient with dehydration, dark concentrated urine, and antidiuretic hormone is at work, right? Because we want to dilute them. These mechanisms keep the osmolality tight, 285 to 295, and this ensures enough blood volume for circulation. And then this is why we're so concerned with urine output in terms of dehydration, and we're so concerned with mucous membranes. These are the first tell signs without having to get terribly invasive. Osmolality and volume imbalances show up in many conditions. So, for example, dehydration, high osmolality, concentrated blood, this triggers thirst and antidiuretic hormone to be secreted. But if the patient can't drink, then you'll see symptoms like confusion, low urine output. You might give IV fluids to and labs, check the labs like the sodium. In something like heart failure, excessive volume from sodium retention causes edema. So now you're checking weight and lung sounds and you're giving diuretics. If they have something like SIADH, which is too much antidiuretic hormone, that leads to water retention and low sodium. That causes confusion, seizures, so you're now restricting the fluids. And I know it's controversial. Some restrict, some don't. It's not the point of this class. I'm just giving you the theoretical overview. What you wind up doing in clinical practice is what you wind up doing in clinical practice. Your assessment in terms of checking things like skin turgor, mucous membranes, urine-specific gravity, sodium levels, these all help catch the imbalance early so you can educate patients and know what to do with them. So compare osmolality to the saltiness of the blood and ADH to the water-saving valve of the kidneys. Okay, good. So let's talk about this renal handling of water and sodium. The proximal tubule, thick ascending limb, distal convoluted and the collecting duct. So the kidneys filter blood through nephrons, and specific parts of the nephron resorb sodium and water to keep osmolality volume stable. So this now is going to show you how each segment of the nephron contributes and helps so that you can understand why urine output or sodium levels change in different disease states. So let's talk about the proximal tubule. This reabsorbs about 65% of filtered sodium and water in the isomotic in isomotic ways. In other words, this keeps the concentration the same in the plasma. That's the proximal tubule. Think of this as the kidney's first pass grabbing back whatever water is going to be lost. Well, it grabs the sodium and the water always follows the sodium. This is what prevents a massive fluid shift. For example, in dehydration, this is the thing that's basically keeping you from dying immediately. It's buying you time. The thick ascending limb, this reabsorbs sodium, potassium, and chloride via special transporters. But it's impermeable to water. So it's only pulling the electrolytes because that's the thing that's going to kill you even faster. The whole point of the water is to transport those electrolytes around. So this creates a concentrated medulla in the kidney, and this sets up the ability to make concentrated urine later. So that's why the urine is getting more and more concentrated because we're trying to retain those electrolytes. This is why loop diuretics like Lasix target this area because it helps wash them out. If the electrolytes build up too much, then you get the downstream effects. So what we want to do is get them out because too much electrolytes built up in the body, say potassium, that's generally bad for many things, but specifically your heart. So this is, if there's damage to that tubule, we're going to give something to force the excretion. The distal convoluted tubule, this reabsorbs sodium and chloride through different transporters, sensitive to thiazide diuretics. So this is where your hydrochlorothiazide would work. The loop diuretics work at the loop of Henle, and the thiazide diuretics work here at the distal convoluted tubule. And this affects blood volume. This is used to treat, obviously, things like hypertension and the like. Lasix is not our first go-to typically for hypertension. Now, the collecting duct is where the collecting duct, this is where cells reabsorb sodium. And it's controlled by aldosterone, which also causes potassium secretion. So aldosterone excess, like in hyperaldosteronism, can cause low potassium. In conditions like SIADH, too much ADH leads to excessive water resorption, and this dilutes the blood sodium. So why does this matter for us? Well, the kidneys are handling sodium and water directly, and it impacts conditions that we're managing. So things like heart failure, sodium retention in the collecting duct, this all increases volume, and this can worsen edema. All right, let's talk about hormonal control of water and sodium. So this is the renin-angiotensin-aldosterone. So now we've seen how the kidneys manage sodium and water to keep fluid balanced, and now I'm going to focus on the hormonal aspects of this. So the RAS, arterial natriuretic peptide, sympathetic nervous system, and antidiuretic hormone. These factors also help regulate fluid. So the hormonal systems, the four hormonal systems that control sodium and water in the kidneys, each respond to changes in blood volume and osmolarity, affecting conditions that you will commonly see. The first one we'll talk about here is the renin-aldosterone-angiotensin. When blood pressure is low or sodium levels are low, the macula densa in the nephron, the kidney interprets this as a threat to circulation. So when the blood pressure goes down, when you're hypoperfused, your body needs to do something to get that pressure up so you can perfuse your vital organs. So the way it does that is it releases renin. Renin acts on a protein called angiotensinogen. That's made by the liver, and it converts it into angiotensin 1. The ACE action, the angiotensin converting enzyme, which is released by the lungs, converts angiotensin 1 into angiotensin 2, which is a potent vasoconstrictor. That's what gets the blood pressure up. It narrows the blood vessels, and it raises systemic blood pressure quickly. That stimulates the release of aldosterone from the adrenal cortex. The job of aldosterone from the distal nephron and collecting duct is to reabsorb the sodium, because we're ultimately trying to increase blood volume and blood pressure. So here's the deal. when you say blood pressure, you need to figure out what is it you mean by blood pressure. There are 4 factors that control blood pressure. They're the 4 things that we manipulate if I want it to go up or if I want it to go down. First thing that controls blood pressure is what? What do you think? Think about all the meds you give for blood pressure. What do they do? Name a blood pressure medicine. Metoprolol, good, beta blocker, right? What does it do? Slows the heart rate down, right? Okay, so heart rate, number 1, heart rate affects blood pressure. What's another type of blood pressure medicine you give? Losartan. What does that do? Angiotensin receptor blocker. What does that do? How does it bring the blood pressure down? What does it do? What does it work on? And what does that affect? Got it. What does it affect? What's the end result? What's it working on? What did I just say angiotensin 2 is? Vasoconstrictor, right? So it dilates it. Okay, so that's vascular resistance. That's number 2. Heart rate and vascular resistance are 2 components of blood pressure. What is another class of blood pressure medicine you may give? Diuretic. Okay, good. That's component number 3. Volume, heart rate, vascular resistance, volume. What is another component of blood pressure? What might make it go up or down? My ICU people should know this. What? Stressors. Well, that's vascular resistance. That's vascular resistance. Vascular resistance. Dobutamine. What does that do? Dopamine. What does that do? It increases contractility, right? So the 4 factors that affect your blood pressure are volume, vascular resistance, heart rate, and contractility. Those are the 4 things you're playing with here. So when we're explaining how these hormones work, what we're doing is we're manipulating those 4 parameters all the time. That's all we're doing. That's all we can do, right? If I want to bring your pressure up, I fill you up with volume, or I squeeze the vessel, or I increase the contractility, or I drive up the heart rate. That's your option, right? Now, your pressure could obviously go down if the heart rate's too fast. So what do? I slow down the heart rate, allow more filling, the heart fills up, you beat better, we're good to go. But those are the same 4 parameters that are constantly being manipulated in the process. So for example, in heart failure, this system, this renin-aldosterone system, this hormonal control is often overactive, and that's what causes the fluid volume overload. So sometimes people are hypertensive because they have an overactive aldosterone, right? And so you treat that differently than, say, if you were to, you're not just going to give those people diuretics, you're going to contend with the aldosterone. Think of the RAS system, it's RAAS, but RAS for short, in your body as the internal fire alarm. This is when the pressure drops, the alarm, renin, triggers the cascade of angiotensin 2 and aldosterone to bring in more water, squeeze the pipes, restore the pressure. But in heart failure, the alarm won't shut off. So we give it something to silence. Okay, that's the distinction here. Sometimes the pressure is too high, sometimes it's too low. It's more dangerous to be too high or too low? Too low. That's right. It's more dangerous to be too low. Too low means blood's not circulating. You're going to be horizontal in a minute. Okay. The arterial natriuretic peptide. This is the opposite of the RAAS system. This is when the heart's atria stretches from high volume, like in the heart failure. ANP is released. It tells the kidneys to excrete sodium and water, reducing blood volume and pressure. Think of ANP like a natural diuretic. This counteracts the RAS system to prevent fluid overload. So you'll see this effect when monitoring urine output and fluid volume overload. So the body's got these compensatory mechanisms that too high will do this, too low will do that. The sympathetic nervous system in low volume states, like say bleeding or shock, this causes constriction of the afferent arterioles in the kidney, and it lowers glomerular filtration so we can hold on to some water. And so we can hopefully raise the blood pressure. And it also stimulates the RAS system. It like kicks the fire alarm and say, hey, we're dying here. Do something. So you will notice that in hypotensive patients with low urine output, this is typically mediated by the sympathetic nervous system. It's driven to conserve fluid. Okay. So yes, it's poor perfusion. Low blood pressure is basically poor perfusion. By the way, that's what we mean when we talk about perfusion, when we talk about stable or unstable, that's code for what's the blood pressure. And what's the blood pressure? Meaning, is it good enough to perfuse the brain and the vital organs, right? Too high or too low can be a problem also. So we've seen ADH before. It's released from the pituitary when the osmolarity is high or the volume is low. ADH acts on the collecting ducts. SIADH is released and it causes water retention, dilutes the sodium. So you'll monitor this in patients with neurological symptoms as well. Let's see here. In heart failure, overactive RAS and low ANP lead to sodium retention. That causes edema. So you'll give diuretics, monitor the weight, check lung sounds. In shock states, for example, the sympathetic nervous system will conserve fluids, reduce urine output, so you're assessing perfusion of the vital organs. And so you have an assessment to figure out what is going on based on how the body responds. Okay. Now let's talk about disorders of sodium. Hypernatremia, that's a sodium greater than 145. So there are two disorders. You can be hypernatremic or hyponatremic. I hate hyponatremia more because there's so many different ways this thing could go. So each has a distinct cause, and your assessment will help guide treatment. So let's talk first about hypernatremia. That means too much sodium relative to water, usually from dehydration, or excessive fluid loss, so diuretic. Diabetes insipidus can cause this. Osmotic diuresis, meaning the glucose is too high, say in someone with hyperglycemia, and so it's a diuretic and they're peeing out. Someone with fever or burns. Rarely is this from someone eating too much salt. I mean, you have to eat a lot of salt for this to move because your kidneys are great at excreting it. So symptoms of hypernatremia would include irritability, neuromuscular excitability, seizures, cell shrinking. Why might the cell shrink? Because the fluid's being sucked out of the cell because of the sodium in the surrounding tissue. Good. The other one we talk about here is hyponatremia. And also, you never want to correct these things fast. And we'll talk more about that later. But these things did not happen quickly. You don't want to fix them quickly because you realize the body has adapted and compensated over time while this pathology was developing. So you want to equally allow enough time for it to compensate while it's resolving. Hyponatremia is low sodium relative to water with 3 types. So you can have hypovolemic hyponatremia. That's low volume. So this is someone that's vomiting. This is someone with diarrhea. The body loses more sodium than water. And so the blood is dilute. You can also have euvolemic hyponatremia. That's normal volume. This is typically from SIADH. Now, if anyone's going, a lot of medications can cause SIADH. Many of the psych meds can cause SIADH. And so typically, and also psychogenic polydipsia. This is the person that can't manage to drink enough water and they can dilute their sodium as well. And finally, you can have hypervolemic hyponatremia. That's high volume, like in the case of heart failure, cirrhosis, nephrotic syndrome. That's where the water is being retained and the sodium is being washed out. I'm sorry, did I just refer that? The water is being retained, therefore we're diluting the sodium. Okay, so that's what makes them hypovolemic. So symptoms obviously include things like nausea, headache, confusion, and seizures. And the cell will swell from the low osmolality. So you have to assess fluid volume status. You're looking for things like jugular venous distension, urine output, neurological checks, so seizures, clouded sensorium, obtundation. And hyponatremia can be life-threatening. So here are the 3 types of disorders with antidiuretic hormone and water handling. Antidiuretic hormone disorders include central diabetes insipidus, nephrogenic diabetes insipidus, and SIADH. So those 3 conditions are related to antidiuretic hormone. One, the brain is not producing enough. The other, the kidney's insensitive to it. And the other, we're making too much antidiuretic hormone. Central diabetes insipidus occurs when the pituitary produces too little ADH, often due to a head trauma or pituitary surgery or tumor. Without ADH, the kidneys can't reabsorb the water, and that causes massively dilute urine. So these people are putting out like 5 to 10 liters a day. That's how much urine we're talking about. Hypernatremia, sodium goes over 145 and then the blood becomes concentrated. Nephrogenic diabetes insipidus is when the kidneys don't respond to antidiuretic hormone. And SIADH, excessive, is most commonly the most, if it's not drug induced, then that should raise your index of suspicion for a small cell lung cancer. Okay, what time is it right now? It's 4:08. We're going to do a break in 5 minutes. Okay. Let's talk about this now, about potassium. So potassium is regulated through shifts between cells and blood through the kidneys. Too high and too low will cause you many problems. Normal plasma is anywhere from 3.5 to 5. Potassium is an intracellular ion, intracellular electrolyte. So you can tell all of your intracellular electrolytes have pretty low numbers. So when they get high and they start to float around, that's what causes the brain to act differently and tells you how to regulate your fluids. And our goal is to get those electrolytes back in the cell so that the brain is responding to what's circulating around them. So what that means essentially is 3.5 to 5 compared to, say, sodium 135 to 145. That's an extracellular electrolyte. Okay. Magnesium, 2, intracellular. Chloride, 95, extracellular. Okay. So the body is trying to keep things in check based on where those electrolytes are located. So you'll notice shifts across the cell membrane. Potassium moves between the cells and the blood based on hormone levels and acid-base status. Insulin, as you know, those that work in critical care, will facilitate active transport of the potassium into the cell. So will things like beta-adrenergic agonists. So will now, if you think about all of the things you do for someone with hyperkalemia, insulin, albuterol, right? That moves the potassium into the cell. Lasix, that gets it out of the body. The kidneys regulate potassium in the proximal tubule and the thick ascending limb, and there's where about 90% gets reabsorbed. Now, let's talk about some causes. What are some causes you can think of low potassium? But diuresis, yeah, we can cause it to some. What else? What else? Low potassium. Vomiting, yeah. GI distress, good. Those are the primary reasons for it. It's either you're getting it out of the body somehow. So some causes obviously would be vomiting and diuresis. Those are your most common situations. What can cause it to go up? Renal failure, acidosis, yeah. What about drugs? Spironolactone, ACE inhibitors, right? Those are potassium-sparing diuretics. So those things can cause it to shift up. Now, why that matters is they might be okay with just the ACE inhibitor, but then you add on a spironolactone or something else like an NSAID as well. And now you get really into the trouble of compounding medications that can cause adverse effects. What you'll notice, what are some signs and symptoms you might notice with hypokalemia? Besides death. Before death, how will you know it's coming? Change in EKG. Yeah, what might you see? The U wave, right? Yeah. That's basically it. You don't tend to see a lot. Oftentimes, this will be an incidental finding. You listen to the story and then you draw the blood. And if you're fortunate to see the U wave, which is down the road, pretty far gone, but that's where you'll see it. Magnesium is a cofactor for sodium and potassium. The pump is responsible for maintaining potassium in the cell. So if the magnesium is low, the pump becomes less effective and potassium is lost from the cell more easily and wasted. So hypomagnesemia can cause renal potassium wasting. So sometimes if you can't correct the potassium, you need to check the magnesium and make sure that too is regulated. So if you keep supplementing, and that K is not moving up, check the magnesium. You want to get that mag to like 2 to 3, and that might be sufficient to fix your problem. If you give potassium without correcting low magnesium, the potassium will not stay in the body and the hypokalemia will be perpetuated. Why don't we take a 15-minute break? and then we will come back. So we're going to talk now about calcium magnesium homeostasis, and then what's going to happen is we'll get into arterial blood gases, and then we'll end this with immunity. So let's get right into this now. Calcium, this and magnesium are both responsible for muscle and nerve function. Now, let's talk about calcium first. So total normal calcium is about 8.5 to 10.5. Is that in the cell or outside the cell, based on what I told you before? In the cell. Good. Now, that means if you have too much out of the cell, there's a problem, right? Something has to cause it to leak out of the cell. So when you see excess calcium, you have to think, what caused that to happen? What sort of lytic activity or what sort of caused it to flux across the membrane? Calcium is normally regulated by parathyroid hormone, PTH, and it increases calcium by bone resorption and kidney reabsorption. Vitamin D increases gut absorption as well, and calcitonin lowers it. So those are the three things to worry about. Whenever you're doing a calcium workup, if you will, it's vitamin D and parathormone and calcitonin levels. Those are the three things. Hypocalcemia is caused by vitamin D deficiency, malnutrition, low sunlight exposure, those would cause vitamin D deficiency, or hypoparathyroidism. So why might you have that? You can have that post-thyroid surgery, typically, renal failure, renal impairment of vitamin D activation. Low magnesium also impairs parathormone release. And the symptoms would include the muscle spasm, tetany, the classic pictures you have seen. Other things that you can notice, you've heard of the Trousseau's and Chauvat's sign. You know, you pump up the blood pressure cuff or you tap the facial nerve, it twitches or the arm twitches. Those are signs of hypocalcemia and hypomagnesemia. So what you need to realize is these electrolytes are regulated and they flux across the membrane and they will be affected by acid-base balance and fluid volume status. The kidneys are the primary regulatory mechanism of magnesium. Hypomagnesemia, for example, and we call that less than 1.7, can be due to renal loss, poor intake. And the symptoms include neuromuscular instability, tremor, arrhythmia. If you work in OB, what happens in OB if the magnesium is too low and they're preeclamptic, right? So it can also help use it as an active treatment for seizures in preeclampsia and eclampsia. Magnesium is a smooth muscle relaxer, right? So if you think about all the conditions in which you need to relax smooth muscles in, so if you give it too fast, there's a reason the blood pressure will dip, right? Because you've dilated the vessel too much. So the blood pressure will go down. What other condition might you use it in? Well, magnesium is sometimes given in asthma where it's refractory. Why? Because you basically want to relax those smooth muscles of the alveoli to open up the lungs in order to improve oxygenation. So you need to think about these chemicals and these drugs and these processes, not just by the system you're intending to treat, but what are the systemic effects of this across the body? That's, by the way, how off-label things come to be. Okay, you're basically looking at what are the broad effects of these different electrolytes and eventually medications. So a patient with renal failure might have high magnesium, low calcium. So you monitor vitals, EKG, and labs, avoid magnesium antacids because they're not going to be able to clear them. You're going to check reflexes, ECG labs, guide treatment to prevent complications. So have you ever seen a patient with a muscle spasm from low calcium or an arrhythmia from low magnesium? Have you ever seen it? What do you do, or what did you do? What happened in that instance? A lot of PVCs so the myocardium is very irritable, yeah? Right, right, exactly. You correct it, and it's amazing how fast it actually resolves. So what we're going to talk about now is acid-base balance. And the reason we're going to get into this now is because this is one of those things that when this gets awry, you will notice all of those electrolyte derangements and fluid volume derangements that we had previously talked about. So basic acid base, basic normal pH is 7.35 to 7.45. That is a very narrow critical range for enzymes to function properly and cells to function properly. If the pH drops below 7.35, we call that acidosis. And if it goes above 7.45, we call that alkalosis, right? So right away, you know if you're dealing with acidosis or alkalosis just based on what the pH is. Now, patients can develop symptoms like arrhythmias or seizures, so we need to figure out what we're going to do here. The body uses buffers to stabilize the pH by neutralizing excess acids or bases. The main one is bicarbonate, HCO3. HCO3 on a blood gas, CO2 on the chemistry. That is bicarb. Regulated by the kidneys, and it neutralizes acids. It's carbonic acid, H2CO3, which is tied to the carbon dioxide level controlled by the lungs. So the equation, we don't care about what that is, but suffice it to say, there are equations that you will see in your notes. I gave you Winter's formula and the Henderson-Hasselbalch formula. These are corrective formulas given certain states. Do you need to know them? No, you don't need to know them per se. You just need to know they exist, and you need to know that those are factors that are going to be called on when we're trying to really figure out what's going on and how we're going to help the patient, okay? I'm not expecting you to become critical care experts, but I'm expecting you to have some general idea of how all this works together so that when you are talking to the critical care experts and they ask you to do things, then you'll know what is being asked of you and why. Okay. So here are some causes of respiratory acidosis as manifested by an increased CO2, right? And so things that can cause that to be the case. What might cause the CO2 to be increased? Respiratory acidosis happens when the lungs cannot move enough carbon dioxide, so they hold on to it. When we say remove, meaning get them out, the CO2 goes up to greater than 45, and this causes what we would call hypoventilation from, say, COPD exacerbation or a drug overdose, right? So if you think about your drug overdose patient, they're not breathing deeply enough, the CO2 goes up, they become obtundant, right? What do? We hyperventilate them a little, blow off the CO2, bring it down, they wake up, okay? Now, you don't want to do that to somebody with COPD because remember, I told you these problems did not happen overnight. It happened gradually over time. They may have become acclimated to a higher CO2, so that's not exactly something you want to immediately fix. But other things can cause this. Obviously, anything that suppresses breathing, so neurological conditions or things like that can also cause CO2 to rise. The kidneys compensate when the CO2 goes up by releasing bicarb. Bicarb is a base. So we're trying to bring down the acidic nature by putting more base into circulation. So in acute cases of COPD, the bicarb may go up, but it takes a while. So when you check the ABGs, you will notice, are they acidotic or alkalotic? And then you'll figure out what's the driving mechanism. If your CO2 and your bicarb are going in opposite directions, then you probably have two different conditions. Okay, because normally if the CO2 is going up, they're acidotic, the body would compensate by putting more bicarb in the system. But if the bicarb is also going down, which would make them metabolic acidotic, and the CO2 is going up, which makes them respiratory acidotic, something's happening. There's no compensation going on, or you have two conditions going on. So just pay attention to that. The body needs to fail in an organized, systematic fashion. If it's not failing the way you expect it to fail, then you need to look a little more deeply and figure out why is this not going the way you expect it to go. So metabolic disturbances. So metabolic acidosis, that's when the bicarb is going down. There may be a high anion gap. And the primary drivers of the anion gap is this mnemonic here called mud piles. You can file that away for trivia, but this is handy to remember. So if someone has an anion gap, which by the way, the chemistry screen will report it to you. There is a formula for it. It's in your notes. You should generally know how to calculate it when you're looking at a chemistry. But methanol, uremia, DKA, propylene glycol, isoniazid, lactic acidosis, ethylene glycol, and salicylates, mud piles. These are things that can cause what they call a high anion gap acidosis. Normal anion gap causes things like diarrhea because they lose bicarb, renal tubular acidosis, and ureteral diversion. Metabolic acidosis occurs when the bicarb drops below 22 and the pH goes below 735. So by definition, if your pH is less than 735, you're acidotic, and if your bicarb is less than 22, then it's metabolic acidosis. Okay. Now, you don't need to know all of these formulas, but we want you to at least be able to interpret an ABG, and you'll have some ABGs on your midterm and your final, and you'll be able to interpret those, and you'll have lots of opportunities to practice as well. So let's talk about these mixed acid-base disorders where multiple imbalances are occurring together, and the anion gap is trying to help you realize what's going on. So the normal pH is 735 to 45. Lungs control the CO2. Normal CO2 is 35 to 45. Normal bicarb is 22 to 26. Respiratory disorders alter the CO2, and metabolic disorders change the bicarb. And the body tries to compensate one way or another to get that pH into the normal range. Osmolarity is referring to IV fluids, and this ties into the anion gap calculation for sodium. So mixed disorders combine these imbalances, making ABG interpretation a little tricky, but we're going to go through this and you will see, and I'm going to show you a video as well that'll make life easier for you. What we're seeing here are two or more imbalances that coexist. And the anion gap is going to help tell you why might they be in this specific disorder. Mixed disorders happen when a patient has multiple acid-base issues like respiratory acidosis plus metabolic acidosis, or metabolic alkalosis plus respiratory alkalosis. So for example, a COPD patient with respiratory acidosis has a high CO2. With lactic acidosis, say from sepsis, that would be a metabolic acidosis with a low bicarb. And that shows a low pH with both high CO2 and low bicarb. So another case would be someone who's, say, vomiting, and the patient may have metabolic alkalosis with anxiety because they're vomiting. So then they start to hyperventilate and blow off their CO2, right? So now you have this mixed picture. You have respiratory alkalosis and metabolic acidosis. So you will assess the clinical context, like the respiratory rate, the labs, their story, and that will give you an idea of what it is you're actually dealing with. So the anion gap, you should memorize that formula. It's basically chloride plus bicarb in the serum, and then you get that number, add those two together, get that number, and subtract it from the sodium. Chloride plus bicarb, subtracted from the sodium. A normal range is 8 to 12. The caveat is you have to correct the anion gap for albumin. This assumes normal albumin. Now, when you're doing this in practice, there are 1,000 free calculators that you can just take, punch in the numbers, it will spit out the answer. And it will, if it's a good calculator, like MedCalcs is a really good one, it'll even ask you for the albumin level. So it'll even ask you for albumin when you're trying to calculate normal calcium, because that should be corrected for albumin. When you're trying to calculate drug levels, there are different ways to do it, but the calculators exist. The reason I show you this is so you know to go looking for these calculators so you know what you're contending with. Okay. All right, so let's practice here a little bit. This is a euglycemic DKA in a patient taking an SGLT2 inhibitor. Their sodium is 137, their potassium is 4.8, the chloride is 100, the bicarb is 8, and the PCO2 is 20. What do we have here? We have a pure high anion gap, right? What's the anion gap? Can someone calculate it? There it is, right? 137 plus 4.8 from 100, and we get 33. You see that on the left side of the screen there? That's how we calculate the anion gap. So you have a high anion gap metabolic acidosis. The expected CO2 is going to be 1.5 times 8. 1.5 times 8, which is the bicarb. That's the correction. And then you will notice that there's an appropriate compensation. And you'll know that when you also look at this is what's expected. Eventually you'll draw blood gas and you'll see for real what is going on here. So now I'm going to show you this video. This is, you can see this online as well. Let's see if we can pull it up. I have to stop the Zoom. Let me see here. Oh, there it goes. Oh, our volume's not working. That's annoying. Let's see. We're gonna give me a second here. Let me share. Okay, so now we're going to talk about immunity, innate versus adaptive immunity. Innate is what you come with, adaptive is what you develop over time. Innate immunity are things like skin barriers. You all come with skin into the world, therefore that's part of your immune system. You come with mucosal linings, you come with neutrophils and macrophages and dendritic cells and natural killer cells. You come with a complement protein cascade, you come with CRP and fibrinogen, and you come with PRPs and toll-like receptor cells, and you come with cytokines. All of that, you're ready for life. You're born with that stuff, assuming all things are normal. Okay? Adaptive immunity, this is what happens to you over time. You've heard what doesn't kill us makes us stronger. Well, this is how it makes us stronger. The B cells, first up, these cells recognize antigens and through B cell receptors. And they differentiate into plasma cells that secrete antibodies. And the first major antibody we're going to talk about, and you need to be familiar with them, is IgM. IgM evolves into IgG. How does it do that? Well, IgM means you're miserable and you're acutely sick, and IgG means you were sick and it's good and gone. And that's how you can remember the difference between IgM, we're actively sick, and IgG, have been exposed and you're better and now you're stronger for it. IgA, that lines your mucosal layers, the mouth, the urethra, all the mucosal layers. And IgE, that is the one that's responsible for wheezes and strange diseases. Okay, so that is like your anaphylactic antibody gamma globulin. So those are all as a result of your B cells. The T cells, which include CD4, helper T cells, T7, Th17, TREG, CD8, cytotoxic cells. If anyone's interested in hematology, oncology, allergy, or immunology, if that's where you want to go into, then you'll just have a general working knowledge of this and you have something to build on. And why would I need to present all this to you? Because most AGNPs, FNPs don't necessarily all work in primary care. It's not uncommon to see you guys wind up in a host of areas, acute care, specialty clinics, and the like. So all of these lessons are basically going to be foundational lessons in the different systems of the body as we progress. So if you're interested in critical care, acute care, immunology, allergy, this was your lecture to build on for your future career. Okay. The next one we'll talk about other things as well. Genetics, et cetera, et cetera. So as we move forward, keep in mind, innate immunity is the first wave of defense, and adaptive immunity is like the precision guided, we've been exposed to this, we're ready to fight this. So that's the major thing to keep in mind there. Pro-inflammatory cytokines. We like inflammation to a degree. It's an adaptive mechanism. Unlike the internet, inflammation is good sometimes. We don't want to go around suppressing all inflammation, but we also don't want it to be in overdrive. IL-1 and TNF, these are primarily released from macrophages. What are macrophages? Those are the cells that get released in the body that come around to eat up all the whatever debris is left after you're done fighting the war, cleans up the battlefield. That's what a macrophage does. And it's among the earliest cytokines released. These are the things that cause you to have fever. These are the things that increase vascular permeability. They lead to swelling and they upregulate and they form adhesions. These are the things that are going to save your life. IL-6, this is the powerhouse that stimulates the liver to make acute phase proteins like CRP and fibrinogen. Now, if you can't help but watch a TV show and you see all these ads for the monoclonal antibodies, pick your drug, whether you have psoriasis or eczema or ulcerative colitis or whatever. These are the things the monoclonal antibodies are targeting, these receptive ones, these various interleukins. So you will listen very carefully to that announcer and he'll say, works against IL-16. What? What did he say? Yeah, well, this is what we're talking about here. IL-8 is a chemokine. It's not a cytokine per se, but it plays a pivotal role in neutrophil recruitment. IL-8, it's a chemokine that recruits neutrophils. So if you see pus at a wound, likely IL-8 has recruited the neutrophil there. It's trying to sequester, localize, seal off, make it all just here so you don't get septic. That's what we're trying to prevent. In addition to these cytokines, we have a complement cascade that gets released in response to various triggers for inflammation. The complement cascade is part of innate immunity. Remember, I told you you're born with these things? This is the stuff you come with. It's the initial something bad is happening, release everything until we can get the special forces in there to do the specific thing we need done. This is part of the large invasion. That's what the complement cascade is for. Think of this like a biochemical domino effect that directly kills pathogens, or at least marks them for destruction when the backup brigade, the adaptive immunity, comes in. So there are three activation pathways. There's classical, alternative, classical, alternative, and lectin. The classical is triggered by antigen-antibody complexes. This is the most common. It's adaptive immune response, and it intersects with the innate tools, so meaning what you were born with. The alternative is when it's initiated by microbial surfaces. So this is, oh, strep again. Here we go. Let's go. We understand, we recognize. Let's move forth. The alternative is antibody dependent. So in other words, you need to be exposed, make the antibody. The next time this thing comes around, we have a way to attack it. Lectin is activated by the mannose binding lectin. This binds to sugar and residues, residues on the pathogen. So it's a key complement protein. Mast cell degranulation is involved in this process. So what do the mast cells do? They release the histamine, and that whole cascade kicks in. So basically what we're saying is this is the reason the symptoms you see are developing. This is the neurochemical and the biochemical pathway as to why what you're seeing is developing. So the non-specific marker of inflammation will be something like, oh, he's got a high CRP and a high fibrinogen. That doesn't tell you exactly what's going on. It just says something is going on, right? So you know that IL-6 is active for some reason. This is why people don't like to draw CRP and ESR, because it could be a whole lot of things going on. It may not be clinically significant, but you're going to open Pandora's box and you're going to have to now investigate all of these things, and it's not cheap. So you should just know that these are non-specific markers of inflammation. The more of them that are inflamed or elevated, the more problems you may likely have, but you don't know what you specifically have. These are non-specific. Okay, so what happens when the cellular cascade kicks in? Well, this whole shift of inflammation leads to vascular changes. Inflammation begins with something as simple as redness, swelling, heat in the blood vessels due to dilation, and it's the histamine that causes that vasodilation. We give the antihistamine to block it, and so hopefully that will reduce some inflammation, or at least the redness and swelling that's related to it. Leaky vessels leak the protein out, and that's what leads to the swelling. And the leukocytes extravasate. Leukocytes are also proteins. They're just cell types. And neutrophils are the main first responders. So when you see a bump in the neutrophil count, you know you are early in the immune response phase. A neutrophil is the first to the scene when you're trying to fight off an infection. Phagocytosis and tissue effects. Neutrophils recognize and then engulf a microbe, and then they destroy them by using toxic substances. Now, while this process kills pathogens, it can also damage nearby healthy tissue. So the clinical relevance, of course, is inherited problems with neutrophil movement, cause delayed wound healing, and frequent infections. So if you don't make enough neutrophils, you are more prone to contracting various infections because you don't have a defense system. So we used to put you on something called like a neutrophil diet or a neutropenic diet. If your neutrophils are down, you're not able to mount a response. We don't want you exposed to all of creation because you're going to catch something and die of it because you don't have the response mechanism in place to contend with it. Chronic inflammation and granulomatous formation. So chronic inflammation is what happens when the acute inflammatory response fails to clear the trigger, or if the body then mistakenly decides to target itself. And that's what we mean when we talk about autoimmune conditions. So acute inflammation is like a sprint. Chronic inflammation is this marathon of despair. And often that leads to damage of healthy tissues. So you move from neutrophils in the acute phase to a mix of macrophages, lymphocytes, and plasma cells. So you will see those numbers start to come up the later on in the infectious phase that you're at. Early on, it's primarily neutrophils. How long have you had this? So this is why when someone presents with symptoms and you ask, how long have you had this condition? That helps you realize what you might need to look for in terms of what cells might be manifesting in the blood count. So, if it's an acute situation, you can say, well, let's see how this rides. And then you're going to be able to see, are you indeed clearing this? We're just going to support the body's healing. If you're not clearing this in the appreciated amount of time, then maybe you need to do something to support the body along the way. This is normally driven by one of three processes. Either you have a persistent infection. This could be something like tuberculosis, this pathogen that can resist degradation and can live inside macrophages. This is chronic infectious causes. So that's why we have something like latent TB. It's in there, it's growing, it's replicating, it hasn't quite declared itself to you, but we like to treat it early before it declares itself to you. Could be autoimmune disease like rheumatoid arthritis or lupus, right? These are chronic inflammatory states. So the body mistakes its own tissue for an invader. And then foreign bodies. So you might have like a splinter that you got when you were 5 that's still in there and you're 45. And all of a sudden, why is my hand swollen up like this? Or something like that. So something non-degradable that's in the body. A granuloma formation is a special type of chronic inflammation. Granulomas are like biological containment units. So when you do an X-ray and you may see something like this round glass appearance, granulomatous pattern, something happened at some point where the body had an infection that it tried to wall off and keep from invading. And that's what a granuloma formation is. It doesn't mean it actively needs to be treated, though. It's just giving you insight as to what was there at one time. Macrophages, these things get activated by persistent antigenic stimulation. So these are the cleanup crew I told you about. They transform into epithelioid cells, and they resemble epithelial tissue more than a standard phagocyte. And these things merge, and they form multinucleated giant cells. And then these are what are eating up the battlefield of despair that's left behind. Now, what are some signs and symptoms of a chronic inflammatory state, might you notice? We're in the post-COVID era. What are some signs and symptoms you've heard people report with their long COVID? Say again? Pain, vague, yeah. Shortness of breath, fatigue, intermittent fevers, variable appetite, right? All of these are signs and symptoms of chronic inflammation. Now, the question is, you may not see these elevated inflammatory markers because the body may be doing a really good job compensating. It doesn't mean it doesn't exist. Most people do not have group hallucinations. So if you've got multiple people complaining of this situation, just because you cannot see it on a blood test, it doesn't mean it doesn't exist. So you have to be mindful that, are they telling you the symptoms that you are knowing they should have before it actually shows up in the blood work? All right, let's talk about the pathophysiology of this sepsis versus capillary leak. Sepsis begins when bacterial endotoxins from, say, gram-negative bacteria bind to the toll-like receptors on the macrophages. This activates the tumor necrosing factor. That triggers the cytokine storm. The interleukin pathways are activated, endothelial permeability increases, and we have leaking protein and swelling. So this is what happens in sepsis. The labs you may appreciate, what are some labs you notice? Anyone work in acute care? What is the sepsis protocol that we do when we're lactic acid, right? And what else? This ABGs and blood cultures and CBC, because we're looking for elevated white count, right? And also respiratory rate, heart rate, vital signs, right? So all of those are basically markers of inflammation. We're trying to catch the sepsis early. So lactic acidosis can arise. And basically, if you're seeing lactic acid, that means poor perfusion has occurred somewhere, right? And when we say poor perfusion, that means lower blood pressure in that part of the body for some reason. How is the pressure lower? Increased capillary permeability, leaking of fluids, the pressure is down, the vital organs aren't being perfused, the cells are dying, the lactic acid is going up. Exactly. All of that is due to poor perfusion. So in general, this is my theory on most disease. All disease, no matter what the disease is, at some level is going to be due to poor perfusion. If you look up any pathophysiology of any condition, you're eventually going to read the line that says, due to poor perfusion of fill in the blank, right? So if you are not getting the good stuff in and the bad stuff out, essentially what circulation does, what good perfusion does, then you will start to see signs of death. One of the signs of death is when you see lactic acid start to go up. And we don't want that because death is generally bad. Okay. Let's see here. Nephrotic syndrome, hypoalbuminemia. I feel like we beat that dead horse. What is this here? Acute pancreatitis and third spacing. This is another inflammatory process. It's huge. You don't want to miss it. This is a condition that occurs with premature activation of the pancreatic enzymes, and the pancreas essentially auto-digests itself. And how do you know what's going on? You will notice increased cytokines or release of IL-1 and TNF. You'll also realize high elevated pancreatic enzymes. When you see this, and they have the constitutional symptoms to match, you know you have a condition of acute pancreatitis. And of course, because where protein if the protein starts to leak out, the fluid starts to build up, they get anasarca, edema, eventually renal insufficiency and failure. If this is going unchecked, this is one of those things that can set the cascade for SIRS. You familiar with SIRS? Systemic inflammatory response syndrome, right? So all the organ systems are hypoperfused. You have inflammation at all the organ systems. And then if you don't treat this, you'll get multi-organ failure. And the ones we care about are the heart, lungs, kidney, brain, right? Those are the ones we really care about. And so, and you can develop pulmonary conditions like ARDS, and eventually, if you keep that going, you can develop DIC and ATN, and the kidneys fail and the liver fails and you bleed out, and that's a horrible thing. But suffice it to say, none of this happens overnight. All of these things are due in a stepwise fashion, in a means of trying to compensate and protect the body. Anaphylaxis, this is an IgE-mediated response. This is an allergen binds to the IgE on the mast cell. The mast cell is interleukin spits out onto the mast cell. The mast cell releases histamine, right? What does interleukin spit out? It spits out leukotriene. So if you think about an allergic reaction, of all the different parts of an allergic reaction and the medications you give, right? So we do things like antihistamines, like what? Benadryl, right? Antihistamine blocks the histamine from being released. But what do you do with the histamine that's already been released? It needs to get to the receptor site. So what we give in that case is a receptor blocker. So that's why you may sometimes give an H2 blocker to somebody that's having an allergic reaction. What's an H2 blocker? Famotidine, Pepcid, right? Like, why are you giving this allergic reaction person Pepsid? Because there's histamine in circulation. I want to block it from getting to the receptor site so they don't manifest. So I'm giving antihistamine to keep the histamine from being released, and I'm giving an H2 blocker to block whatever's already in circulation. So what about something like, well, what if I don't want the histamine to be released and I don't want the mast cell to be activated? What's in my cascade then? Well, I need a leukotriene inhibitor, something to keep that mast cell from firing out the histamine. What's a leukotriene inhibitor? It's only one. Singular. That's the one. So if you're having an allergic reaction, I may give you a little singular. I may give you a little antihistamine. I may give you an H2 blocker. And if I want to turn a fire hose on the whole situation because I don't know what the heck I'm dealing with, what do we give you then? Steroids. Exactly right. That basically suppresses all the inflammation across the board, turn the hose on everybody, right? And if the allergic reaction is bad enough, you just spray it all down and let's see what happens. Now, you can kind of figure out what happens based on the half-life of all these drugs. As they wear off, you see what flares up. As you see what flares up, you figure out what's still in circulation and what do you need to do. Okay. So in asthma and severe anaphylaxis, it's not abnormal to give those things. And of course, these things about like, epinephrine and all of this sort of stuff, all of that is essentially trying to maintain perfusion and blood pressure, so bring down swelling, etc. Time is of the essence when you're trying to restore perfusion. Okay, so let's talk about capillary oncotic pressure. Well, no, we did enough of that. Protein keeps the blood in the vessel. We don't want it leaking out. You get the point. Hypoalbuminemia, you're going to notice some swelling and a sarco-dependent edema. You got to figure out what's causing it. Capillary permeability, we talked about that already. We're rinsing and repeating here. Hyperkalemic changes, we talked about the EKG. The potassium is outside the cell. We want to get it back inside. Some symptoms of hyperkalemia would be the peak T wave. Progression can lead to QRS widening, U waves, flatten the T waves, VFib. Bad. Okay, you'll get frequent PVCs with this, and bad things occur. So we want to basically get the potassium back in the cell. Now, what medications can contribute to hyperkalemia? We talked about this already, the ACE inhibitors, the potassium-sparing diuretics, and if they have chronic kidney disease. Those are the things that can cause that. We talked about SIADH and the dilutional hyponatremia. Inappropriate antidiuretic hormone, that's what retains the fluid that results in the hyponatremia, not caused by GI losses. High anion gap, we talked about this already. Metabolic acidosis, the body compensates with respiratory alkalosis. How do you do respiratory alkalosis? Breathe too fast or too slow? Good. Right? I'm blowing off the CO2. That's fast. If I breathe slow, I hold the CO2. You got to really think about what is the person doing. Okay. Conditions like lactic acidosis, DKA, renal failure, these take a long time to develop. So hopefully the lungs will compensate in the process. So what you'll notice is their respiratory rate progressively gets faster over time. They're being tachypnic, which we often label as short of breath, but they may not be short of breath. They're just breathing faster. They're breathing faster because they want to compensate for that metabolic acidotic state that they're developing. Okay, low bicarb, low pH, metabolic acidosis. It's not due to respiratory issues. Okay, here we go. Hypernatremia and water deficit. This is commonly due to free water loss, sweating, diuretics, NPO. Sodium concentration rises when the water is not replaced. We talked about SIADH. You're going to be very familiar. Hydrostatic pressure in CHF. The venous congestion from right heart failure raises capillary hydrostatic pressure. If you have right-sided heart failure, where is it backing up to? To the body. And if you have left-sided heart failure, it's backing up to the good. And that's where you're going to find your signs and symptoms. So you kind of know where to look. Okay. There will be a whole lecture on cardiac, but it's good that you think more systemic now. And nephrogenic diabetes insipidus. What's the problem here? Nephrogenic diabetes insipidus. What's the problem? The kidneys are not responding to ADH. And ADH is produced where? In the pituitary. So if I give them vasopressin and the problem does not resolve, is it nephrogenic or central? Nephrogenic. Slide number 1, people. Okay. If it does respond, that means the kidney is not insensate to the vasopressin, right? It means the kidneys is not the problem. It's a brain problem. You can send them home on nasal spray and they're going to live on it for the rest of their life, maybe. Yeah, vasopressin nasal spray. 1 squirt every other nostril. Every other day, each swab nostrils. Every other nostril. It's been a long day. All right. Suffice it to say, hyperchloremic metabolic acidosis, normal anion gap acidosis, the bicarb loss is replaced by chloride. This is common in diarrhea, renal tubular acidosis, and it's not driven by lactate. Lactate will rise later on when this person starts to die. Okay. Hypokalemia, loop diuretics wash out the potassium. You'll see U waves and flattened T waves. Arrhythmia develops. Hyperkalemia has the opposite effects on the ECG. And then calcium and magnesium are given. The calcium is for myocardial stabilization to keep those ions from, contracting excitably. And the magnesium also to regulate the potassium pump and for smooth muscle relaxation. Chronic respiratory acidosis. Yes, ma'am? No, but all of it. Yeah, your hospital's not doing the whole cascade. Yeah, you get the whole spectrum. So if someone is hyperkalemic, you want to go ahead and do the D50 and 10 units of insulin. You can start the albuterol, give them a little Lasix to wash it out, assuming they have kidney function to do it. I don't know if Kayexalate is in style anymore or not. Do we have that even? There's another one that's around. What are we using now? Low-cal. Okay, see what happened there? Marketing. For 20 years, we use Kayexalate. All of a sudden, the shortage, let's put a new drug on the market and charge a lot more for it. Yeah, you can induce diarrhea in a host of ways, by the way. That's kind of what you're doing. Say again, the new drug doesn't cause diarrhea. What does it do? It just binds it, and where does it go? So where does the potassium go? Stays where? Outside the cell? That's bad. I think you should look up the mechanism of action of the drug so you know exactly what's happening with the drug. So by the way, if you don't have a drug guide, you should have a drug guide that you regularly look up all the drugs. Now, I'm not teaching pharmacology. That's after this class, I think, right? May the Lord bless you and keep you. But suffice it to say, you should get to know your drugs by mechanism of action. That mechanism of action will help you understand how the pathophysiology ties into it. Don't do Madison Avenue marketing reasons for drugs, okay? Pepsid is not for reflux. Pepsid is an H2 blocker. Got it? Don't do that. Don't do, anti-inflammatory. You need to specifically know what is it doing. Beta blocker means it's slowing the heart rate. Don't say blood pressure medicine. Okay, you need to be a lot more specific because that will help you figure out how these drugs actually work. So I will recommend to you that you study pharmacology by classification and mechanism of action so that when we talk about the stuff in patho, you will have some idea of how they're related. And that will make your studies easier. I don't know if our lectures line up, by the way, but suffice it to say you'll have a good foundation here. Acute respiratory alkalosis, this is triggered by hyperventilation. So think about this. Respiratory alkalosis, breathing too fast or too slow? Too fast. CO2 is quickly lost, the pH is rising, bicarb remains normal. Okay, good. Lactic acidosis in shock. What's happening here? The tissues don't get enough perfusion, anaerobic metabolism ensues, lactic acid builds up. This is the same lactic acid you get when you do a good workout at the gym. But it's all a matter of dose, right? That may not kill you, may feel like you're dying, but not going to kill you, assuming, and what do we tell you to do? Hydrate, right? Because we dilute and we massage to work out the lactic acid, and eventually your body will metabolize and excrete. That can build up, though, to cause metabolic acidosis. I was just watching that, what's that new documentary or on Netflix about The Biggest Loser? Did you see the new documentary on Netflix? So what they took is this very large person and told him to run a mile, which is bad because what happens is those muscles broke down and it triggered rhabdomyolysis. And when rhabdomyolysis ensues, lactic acidosis follows. The poor woman wound up on life support. It's a hot mess. But suffice it to say, that's what happened. Okay, acidosis due to liver failure. The liver clears lactate. If it fails to do it, you get lactic acidosis. This presents as metabolic acidosis. It's not primary respiratory. And then encephalopathy can occur. And if the encephalopathy does occur, what happens when you're encephalopathic? Do you breathe too fast or too slow? Too slow, right? You become obtundant. The CO2 goes up. That clouds your sensorium. You get sedated, right? That's what happens there. So if you breathe too much CO2, it'll put you to sleep. If you can't sleep at night, just hold a bag over your mouth. CO2 will knock you right out. And then it'll fall away from your face. Self-limiting condition. It's cheaper than, I don't know, it's less addictive. Nobody wants to do that regularly. Metabolic alkalosis from vomiting. Low hydrogens, you're vomiting them out. There's a rise in the serum bicarb to compensate, and we develop this volume depleted state to sustain the alkalosis. Again, this is not due to CO2. The CO2 may go down because the patient will do what in this state to compensate? Breathe faster. That's right. Good. Okay. Neutrophils and histamine and inflammation. Let's see here. What can we say about neutrophils, histamine, and inflammation? Well, they're all related, right? So if you see that neutrophils are the early responders, but here are the nuances. If a patient has a delayed neutrophil response, like say someone on chronic corticosteroids, your asthma patients or whoever's taking steroids on a regular basis, some autoimmune patient or something like that. The implication here for wound healing is diminished. Not zero, diminished. And what about histamine? So the problem, of course, is histamine causes vasodilation and increases capillary permeability. So what you might see on a physical exam of an inflamed area before the labs even come back. Antihistamines provide symptomatic relief, but they don't do anything for the underlying cause of the situation. They suppress the inflammation, but not the cause of the inflammation. So the line is they make you feel great as they kill you slowly. So people feel wonderful on the steroids. The appetite goes up. They're full of energy. They have no pain, but the tissues are becoming so impermeable and blood sugars are climbing and healing is delayed and bad things will follow. Anaphylaxis. Anaphylaxis is mediated by the IgE response. This thing binds to the mast cell. What releases the histamine? The mast cell releases the histamine, right? And what causes the mast cell to release the histamine? Leukotriene. Remember that leukotriene inhibitor? Leukotriene gets spit onto the mast cell by interleukin, and then it releases the histamine. Okay, good. And then IgA and natural killer cells are not involved in acute allergy reactions. So why that matters is if you draw levels and you start to see elevated this level and not that level, that helps focus your thinking. And you can say, oh, this is an allergy response, or this is an immune-mediated response, or this is an active infection. This is a late infection. This is a chronic inflammation. This is acute inflammation. All of these different cell types tell you at what phase of disease you're in. That's why there are so many of them and for you to look at. Granuloma formation. This is due to chronic inflammation. The macrophage and the Th1 cells wall off the pathogen. You'll see this in things like latent TB, sarcoidosis. If you treat people from the developing world, you will maybe see this later in life. I moved to New York 2 months after moving here. I come up with latent TB. Probably caught it on the subway or for some ICU patient, or I don't know who gave it to me. I felt fine. I only found it serendipitously because the one position I happen to work at, we want a two-step PPD. Yeah, I was passing all my PPD exams because all these fly-by-night clinic. Okay, negative, negative, negative. There's one place I went to, no, two-step PPD. Come back in 2 weeks. Let's do it again. Oh my God, I'm positive. Get it. C'est la vie. So we do the drugs. Okay, complement pathway distinction. So alternative pathways, antibody independent, triggered directly by the pathogen surface. So the classical one is antibody antigen. You have this condition because we've had it before. The antibody gets released because it recognizes the antigen. The lectin mechanism is it recognizes a sugar on the bacteria, and the adaptive is what you develop over time. So innate is what you're born with, skin, mucus, complement cascade, and the B cells, T cells are what you develop along the way to be specific towards the whatever's attacking you at the time. Okay, and finally, here we go. Tumor necrosis alpha and interleukin-1, these are the ones that cause fever. IL-6, this drives the liver to make acute phase proteins. And IL-10, this is what is suppressed in the resolution phase. So how can we put this so that it's more memorable? Adaptive immunity doesn't just fight off the pathogen, it learns. But what cells give us that long-term protection? It's the memory B cells and the memory T cells, so that you're not fighting it off for the first time every time. Memory B cells are primed to make the antibodies fast upon re-exposure. The memory T cells, especially the cytotoxic ones, respond rapidly if the same antigen is seen again. This is why vaccines are so effective. So even if you've never had the infection, because vaccines simulate an infection to build memory. So vaccine exposes your immune system to the antigen, either weakened or killed version, and then the body recognizes that and is able to mount a response quickly. Okay. I think that is all I have. So, questions? Tormented you all. You're like, what the heck did we sign up for here? This is not what I thought it would be.